46-year-old woman with history of recurrent stromal herpetic keratitis presented at our department complaining of progressive vision loss in the absence of pain. Slit lamp examination showed the presence of a desmetocele 1 mm in diameter amid diffuse vascularized corneal leucoma. The patient was phakic and the retina seemed detached, but neither the anterior nor the posterior segment could be inspected in detail because of the corneal opacity. A B-scan echography did not detect any abnormality in the posterior segment. Several surgical options were available to treat this case. We ruled out a conjunctival flap and a patch graft in an attempt at obtaining good postoperative vision. A penetrating keratoplasty was seemingly considered unsuitable because of the poor prognosis in a vascularized recipient cornea like this one. Finally, we thought that a 9 mm DALK procedure would be the optimal solution, as it would combine preservation of the recipient endothelium with the optical advantages of a large graft diameter. The problem was, of course, how to perform DALK here. We started the procedure by performing a partial thickness trephination 9 mm in diameter and about 300 microns in depth. Next, we started to dissect the anterior peripheral stroma from the base of the trephination. The crescent knife entered easily into the inflamed tissue and care was taken to maintain the dissection in the same corneal plane. Bleeding was left to stop spontaneously, as cauterization of the vessels would affect the shape of the recipient bed and possibly endanger the thin part of the cornea. The anterior stroma all around the desmetocele was removed with corneal scissors. Handheld trephine was used to mark a central optical zone 6 mm in diameter, including the desmetocele. A side entry was created with a 15-degree blade. In this case, the access to the deep dissection plane was performed through the desmetocele. The blunt tip of a Vannas scissors was inserted in at the base of the area where decimate was exposed. We chose to limit the dissection to the central 6 mm as an optimal compromise to obtain an optical zone large enough also for mesopic conditions while minimizing the risks of perforation. To our surprise, the scissors did not encounter any resistance, as what we believed to be the entire recipient stroma had spontaneously split from the underlying layer. It was impossible to detect whether this layer was pure decimate or included also pre-decimatic stroma. However, the strong resistance of the residual bed to the mechanical trauma of dissection made us believe that the newly identified Duas layer was still attached to the endothelium. We prepared then a donor lamella by means of microkeratom dissection using a 300 micron head in order to match the thickness of the stroma removed from the corneal periphery. The anterior stroma obtained this way was punched to 9 mm, the same size of the trephination in the recipient bed. The donor lamella was sutured into place with 16 interrupted tenonylon stitches. Finally, a 27 gauge cannula was inserted into the side entry and used to remove the fibrin clot from the internal surface of the desmetocele. Corneal integrity was re-established at the end of surgery, although in the central 6 mm where the donor tissue was in direct contact with the recipient decimate, thickness was reduced. However, the presence of Bowman's layer in the 6 mm area with a thickness of at least 300 micron should prevent any negative effect on the final corneal shape, as we have seen in many keratoconic eyes operated on with a similar technique. Postoperative treatment included antivirals and steroids both systemically and topically. As early as 3 weeks after surgery, inflammation had totally subsided and the clear optical zone allowed 20/40 uncorrected vision. In conclusion, stromal melting leading to the smetocele formation may have the positive side effect of creating a cleavage plane that can facilitate dissection of the diseased tissue. By limiting the dissection to the central 6 mm, the recipient endothelium can be safely preserved while a large anterior lamellar graft can optimize the final corneal curvature.